Option Year 1 kickoff call. We're planning to start at the top of the hour, so it'll be about another 5 minutes before we get started. Thanks. Good afternoon, everybody. This is Jason with Intermountain Healthcare. Thanks for joining our Option Year 1 kickoff call. Just a few things before we get started. If you have any questions during the presentation, if you could either type them into the Q&A box or save them until after the call. We'll open all the lines at the end of the call and we can have an open discussion then. And then when the webinar is officially over, there is a pop-up box that will pop up with a survey. And if you could complete that survey and give us some feedback on the webinar, we would appreciate that. And then just as a reminder, when we do unmute all the lines, if you could just make sure to not put us on hold or anything so we don't hear your background music, that would be appreciated as well. So I think with that, we'll go ahead and get started, and I will turn it over to our project director, Lucy Savitz.
Hello, good afternoon, everybody, and thank you for joining us today. We're really excited to have this opportunity to work with you, and I know there are a few people who are new to our HEN who may be on the line, so we want to welcome everybody. Next slide, please. Just for people to understand the expanse of our HEN, we are one of only 5 national hospital engagement networks that are a part of the Partnership for Patients. And currently, there are 96 hospitals that are pledged to our HEN. We serve hospitals across 17 states. 47% of our hospitals are located in designated rural areas. And the data that you see on this slide shows the volume of admissions, beds, and births that are sorry. I apologize. We had a little technical difficulty here. On the next slide, you can see the distribution across different census regions. And as I said, and you'll see in a moment, Secretary Sebelius has established a goal for all HENs that in 2014, all short-term acute care hospitals will be part of a hospital engagement network, which means there are a little over 17,000 hospitals that have currently not been in a HEN. I don't expect that our volume will go up that high, but we will have increased volume. Next slide, please. And on this next slide, it's just another slide to show you the distribution by bed size. The reason the bed size categories are a little odd and not presented in a traditional way is we use natural breaks in our data. And we did this, one, so that we could get a feeling for where our hospitals are at, both in terms of bed size and rural-urban location, in order to provide better tailored reports to you and to better analyze the data so that we can give you more targeted technical assistance. And you'll hear in a moment about some of the expanded ways we're looking to enrich the technical assistance experience for you all. But the other thing that's important to note here is that this is a real opportunity for us to sort of form networks within networks and groups working together on the same kinds of issues and challenges. And we found over the last 2 years that through the affinity calls, a lot of really interesting peer learning has occurred. And I think it's important to underscore that in our HEN, and I think in other HENs as well, you're not in it alone. These are all areas we've all been working on for some time. This is a way that we can sort of find clusters of hospitals so that we can do targeted in-person regional meetings to meet the needs of these groups. The last point I'd like to make in looking at this slide is we have promised every hospital that provides data to us that we will not provide data to CMS for any cell count less than 5. And that's, you know, really sort of an analytic threshold that's been set by the federal government for protection of privacy purposes. So none of the data we report will ever be reported to CMS that identifies hospitals unless it's done with express permission from your organization. And through the success stories, many of which are posted on our website, we have identified hospitals because those hospitals, based on their promising practices, have agreed and given us permission to identify them in that way. Next slide, please. This, I think, is one of the best testaments to the work that we've done collectively over the last 2 years. And I want to be sure that we sort of pause on this. So, as most people on the call know, we've been working to improve patient safety in 10 targeted areas, which you'll see in the dark blue across the top of this chart listed. And the Partnerships for Patients goals have been to reduce healthcare-acquired conditions by 40% and readmissions by 20% by the end of this calendar year, so by December of 2014. Our HEN has actually fared better than most of the HENs in terms of our progress. What you see here is that in 5 areas, we've already reached the 40% goal, and in 2 areas, which are the orange arrows, our performance is below the national benchmark, and so we won't expect to reach 40% because we were already doing so well. In the 3 yellow areas, ADEs, CODI, and readmissions, we still have some work to do, but to say that in 7 of the 10 areas we've made measurable progress is really a testament to the great work everybody's been doing and the efforts that people have been committing to this continued work over time. Next slide, please. So a giant thank you to everybody. We know how hard this work is. We are based in a delivery system. We're doing this same work alongside you, and our commitment to collectively work together and share learning and share, you know, sort of one of the things that I was most struck by on one of our affinity calls, people were having trouble, and this was a particular problem of Epic users. And one of our participants, who is a new Epic user from Providence Health and Services, volunteered to give people sort of shortcuts on how to do the EED measure based on, you know, sort of nuances of the Epic EHR. And it's those kinds of experiences where people step up to the plate and lead together and work together and share those experiences to make it easier for us all to do the right thing for our patients. And we really congratulate you and thank you for doing that. Next slide, please. So these are the value-added services that we've been offering. One is the Just One Thing matrix that's available on our website, and it's always been our position that not everybody starts at the same place. And so what the Just One Thing matrix does is it says, for any of these 10 areas, what do you do if you're just getting started? What do you do if you're working harder? And what do you do if you're working ahead of the curve? We overlaid that Just One Thing matrix that had been constructed by our subject matter experts in each of the areas with the information from the recent HRQ evidence report. And so the Just One Thing matrix that's posted on our website under the Resources tab shows you the strength of evidence associated with all of those recommendations. There are many, many other resources that are available and codified on our website. And so, again, I think it's a resource for people, but also for new people coming on board. We have archived as enduring materials all of the webinars, the training webinars that we've done to date. The tailored data feedback reports, when we have done our quarterly surveys and we ask you, you know, what do you think is important? What do you want to see sustained? The number one activity that in your responses to that survey were that the tailored feedback reports are one of the most important assets that we sort of bring to the table to the group. And we've tailored them in different regions in different ways, and it's something that we're willing to, because of the way the system has been set up, and Jesse Gigi, who's sitting here with me today, has been sort of our main point of contact on the data submissions and actually preparing the feedback reports. And we're willing to work with you to make sure you get the data that you need in a meaningful way. And as you saw in the distribution of hospitals, we have some really good comparators, irrespective of your bedside and your rural-urban location. We also have success stories. A number of you have been highlighted in those success stories. Those are posted on the website, and the purpose is to show what's possible, not just what's possible at, a leading tertiary care facility, but what's possible in small rural hospitals. We've seen success across the board, across, all the states that are participating. So we're really excited to showcase that work. A number of people have been highlighted on the CMS national webinars in that way, and we're excited to continue to do that. Also in the room with me is Marlene Conti, one of our subject matter experts in pressure ulcers and patient falls and immobility. And Marlene is one of our exemplary subject matter experts who's been leading affinity calls. The affinity calls are really a peer-based learning that are facilitated by subject matter experts. And some of the affinity calls have been more successful than others. I think those that have been most successful are those that have high participation of the right frontline staff. Marlene, would you like to comment on that? Like, what makes yours so good?
What makes mine so good? Having an agenda ahead of time, doing follow-up based on the previous discussion, and then asking for input and soliciting feedback from the participants online. We've done several little, right during the webinar polls, to ask people what they were doing and what they were finding to be helpful for specific initiatives. So it's really keeping it focused on the participative and the team learning rather than let me tell you how I'm perfect kind of thing.
Great, thank you. But again, I think the bottom line there is participation is key. So we will continue to do those, and we'll be sending out a schedule shortly for those of you who are interested. So please help get them to the right staff in your organization. We had one of the example stories that was highlighted in an earlier newsletter was a group from the Mayo Clinic where they met together as a team, listened to the affinity call, and then would debrief afterwards and set up action plans for their own organization. So there are different strategies that you can use to make them more or less effective for yourselves. And then we have the monthly newsletters where, we try and scan the literature, we try and scan new things that are happening so that we can help keep you abreast of those things in the newsletters. But the other purpose of the newsletters is to reach deep and up in your organizations. It's a way for you to communicate within your organizations what's happening, what's new, where we at with the Hospital Engagement Network. So these are the things we have been doing. We will continue to do these things, but let's sort of turn a leaf and look forward. What are we going to be doing in the next year? Next slide, please. So these are the additions. I already mentioned the first goal from the Department of Health and Human Services, which is that all short-term acute care hospitals will be in a HEN. And one of our first activities that we've been busily doing, and so you should have been contacted in your organization, is that we're required to re-pledge with C-suite sign-off all of the current hospitals in our HEN. And we're about 72% of the way there. We're still working. If you've not heard from us, then everything is okay. Otherwise, you've probably heard from Jason, and he's trying to follow up on that. We are recruiting new hospitals, and I will tell you that we are open to bringing in new hospitals. There was a group of rural hospitals from Utah outside of Intermountain Healthcare that contacted us. We've had a number of other delivery systems in surrounding states contact us, but also we've reached out to other hospital systems in the high-value healthcare collaborative that are not part of any HEN right now, so that we could get increased high-value healthcare collaborative participation, because we're still looking forward to sustainability of our activities as we move forward. In terms of the expanded focus in selected areas, you'll see 6 areas that are sort of represented here by the dashes, and 2 of them are bolded. And the reason why 2 of them are bolded is we haven't actually selected measures in these areas. Because of the forward-thinking nature of many of our subject matter experts, we've already expanded our measures, so there's nothing new with respect to CLAP, CVTE, VAE, CODI. We're already collecting measures in the areas that CMS is asking us to expand into. But for adverse drug events, we're asked to really include at least one measure on opioid safety, one on anticoagulation safety. We actually do have a metric in warfarin use, but only one hospital supplies data in that area. So we're working with the subject matter experts to sort of revisit the measures and help us align these. And then the last one under ADEs is glycemic management safety. And then the final category that is bolded here is expanding the OB area. And the two areas of expansion that CMS is asking for, one is on OB hemorrhage, and the other is on preeclampsia prevention. Now, recall that this is a hospital-based intervention, and so I will tell you that Dr. Alan Wilcox from NIEHS was in Salt Lake City. Jason had time to meet with him, and we showed him the measures that CMS is sort of putting out there for preeclampsia prevention, and he was sort of, how would you describe his reaction, Jason?
Confused and underwhelmed.
Yes. Thank you. And so we are working with Dr. Wilcox. We're working with other subject matter experts to try and figure out what we'll be doing here. So those two areas will be the two new areas related to measurement, and we'll have training associated with those. And we have met with all of the subject matter experts. We're asking them to revisit our Just One Thing matrix and revisit the metrics that we've been using to make sure that we're, on target, still moving in the right direction, and whether or not anything needs to be updated. And we haven't received any updates to this point, but again, there will be expanded measures in those two areas. We have budgeted, despite CMS's reluctance to fund travel, we have been awarded funds to conduct 3 to 4 regional meetings. And I'll talk in a minute about how we're going to sort of plan those. But I think the major area of expansion is through a tailored technical assistance that I'm calling EXTRA. And I'm actually modeling it after a quality improvement program that's based in Ottawa, Canada. Next slide, please. So the idea here is we want to hear from you. If you're really struggling in a particular area and you would like additional targeted resources to help with technical assistance beyond the affinity calls and beyond just, sort of emails that you send in, this is a higher level of quality improvement support. There's a form that you can fill out, and the way you start the process is to email us at admin@henlearner.org and express interest in the EXTRA program. You'll be sent a little mini questionnaire that has 3 sections. The first section will be just some information about your requesting hospital or system. The second section covers, what you think you need to address in the improvement plan, and there are a series of just very short questions on that. And then the last one is your organizational commitment. And then that will come in, and it'll actually go to Ann Ward, who's actually sitting next to me in the room. And Ann is a longtime expert in quality improvement. She was, do you want to just say a little bit about your past roles in quality improvement, Ann?
Yes, before I was the Assistant Vice President for Quality for Intermountain Healthcare and worked with all of our hospitals and entities to develop quality improvement activities.
For how many years, Ann?
More years than I care to confess.
Ann is being very humble. She's a very well-known expert. She's actually retired, and she's so well-known and so valued by Intermountain that she agreed to continue to work into her retirement with Brent James, and does a lot of work in support of our advanced training programs, our 100% participation. And so she'll be the one who sort of triages these applications. And we'll look at them in a couple ways. One is, does it make sense to do a single consult to your organization? And if so, should it be virtual versus in person? And then the second thing is, do we see a number of different hospitals or systems asking the same sort of questions? So should we put together a small meeting where we would bring people together and do sort of a group session? So there are multiple ways that we can be responsive, and we do have resources. And so most of the resources that we do have available to us will really go towards supporting the extra program in this way, as well as the subject matter experts that are available to you in multiple ways. Next slide, please. So this is what you can expect from the extra program. One is, obviously we try to, as much as possible, rely on evidence-based or evidence-informed improvement interventions. The idea would be to design and sort of help you, work with you in implementing at either an organizational or multi-site initiative to learn techniques, tactics, and strategies that you can use to sort of spread and scale up these promising practices, and then to work with the really dedicated academic mentors. I can't say enough about the caliber of the mentors that we've got available to us, and change management coaches who will work with you to achieve the measured progress in improvement. And again, I've already introduced Ann Ward to you, who is an exemplary QI expert who's available to us to help guide us through this process in the new program. So I encourage you, if you have a specific need, the sooner you get your request in, the sooner we'll be able to honor it and figure out what to do. So think about this as being, a real rich asset that is at no cost to your organization and is available to you. Next slide, please. This is a list of our subject matter experts who are working with us. In year 3, we've made a few shifts, but all of these organizations have, done a lot of leading work in improvement already that's been demonstrated, and the subject matter experts have agreed to take leadership in sharing that learning, marshaling resources, reviewing the literature, synthesizing all of the information that they have, both from the peer-reviewed literature, from their own work, and from best practices across some leading organizations that are involved in our hospital engagement network. So it's a level of learning and knowledge sharing that is really unparalleled. I can't say enough about, just the dedication and the hard work and the timely response our subject matter experts have been able to provide. Next slide, please. So I do want you to be aware of the fact that we are partnering and doing it in multiple kinds of ways. There are a lot of organizations that are working in overlapping areas, and we're very attentive to the federal government's concerns that there not be wasteful duplication of efforts. And so towards that end, we've really worked very hard with the quality improvement organizations, or QIOs, across the 17 states. Some of those partnerships are more active than others. We have coordinated with a number of hospital engagement networks and just very openly shared our learning. I think the best example most recently is with the Minnesota Hospital Engagement Network, where they were having, they had some need for some expert consultants around human factors, which many of you know has been one of the cross-cutting issues we've dealt with. And Dr. Frank Drews has 2 recorded sessions that are on our website. He produced as a Christmas present to everybody 2 Christmases ago a white paper and toolkit on human factors. And so we shared all of that information openly. We made Dr. Drews available to their hospital engagement network. So that's one way we partner with the HENS. There are these new community care transition programs. Some are more active in states than others, and there is some limited ability to participate. But I would suggest that if there are any in your state, figure out who they are and work with them, because a lot of the adverse event areas we're working with cross the care continuum. I think readmissions is probably the best example of that. And they're willing and able to collaborate with us. We've also worked with health departments in selected states, among others. So there are many opportunities, and I want you to be aware of the fact that we've been very open, we've been very transparent, and we've been very forthcoming in sharing what we're doing. We have taken a leadership role in coordinating all of the HEN activities related to recruitment. One of the things that happened in year 1, and for people representing hospitals, particularly if you're in a leadership role, you're probably inundated in year 1 by all the hospital engagement networks trying to recruit hospitals. And we said, let's not do that again this time. You know, it's not good for you, it's not good for us. And so we've led a collaboration across all the national HENs to recruit hospitals. And then now that we've sort of moved through that list, we're moving on to those hospitals that none of the HENs had really expressed interest in. It doesn't mean we're not willing to accept them, but there wasn't a strategic reason we would have identified them as a target. So now we're working to make sure that we get this inclusivity in reaching Secretary Sebelius's goal of 100% participation. And then I want to make you aware of a shared learning opportunity. We try and make these available as early as they become knowledge, you know, that we're knowledgeable of them. We received an email today. We did know about it on Friday, but we didn't get the call-in information to today. It's called Creating a Culture of Safety, the Power of Conversation. This is HSAG, which is a QAO in California. And the webinar is tomorrow. It's Tuesday, February 11th from 9 to 10 a.m. Pacific Standard Time. So if you're interested, the phone number and passcode are here. If you send an email to admin@henlearner.org, we can send you the link to that webinar, and we will continue to let you know. This is probably the least notice that I've ever seen us give people, but I didn't want to not give it to you. Next slide, please. So just a couple of reminders. The repledging forms were due February 7th. If you've not gotten those, and Jason's still requesting assistance, if you could please help us get those in. We want to continue to work with you, and we want to continue to show value and work together. February 20th is the deadline for the fourth quarter of 2013 data submission to Jesse. And Jesse, I believe those reminders have all gone out to folks. We also had reminders of both of these in the newsletter that went out 2 weeks ago. And then, as always, there are many resources that are available on our website at www.henlearner.org, and we continually refresh and update that. And then lastly, for questions and assistance, always email admin@henlearner.org. I just want to emphasize one point. The reason we're asking for the extra program that you email admin@henlearner.org and then we send you the application versus just posting it is because we need to track, and we want to make sure that if somebody expresses an interest, that we're sure that we're tracking and making sure that you're followed up with and that we're aware of what stage you are in the progression of our responses to you. So it's not because we're asking you to do another little administrative bureaucracy kind of thing. It's we want to be responsive to you, and it's the only way we can track and do that. Next slide, please. This is just an example testimonial. We've gotten a number of testimonials, and for those of you who've sent us positive comments, we thank you because it's always nice to have people say nice things about you. And just know that we have included those in our reports to CMS. So we hope that we'll continue to provide value with you. We're always willing to learn and improve the work we're doing. So if you have suggestions or comments, again, they can always come to admin@henlearner.org, and we're happy to receive those. Next slide, please. So our journey continues. You know, these are things we've all been working on for a long time. We'll probably continue to work on them for a long time into the future. So the things that will be available to you are the expanded technical assistance, plus all of the other support services that we have provided. The goal is to drive continuous improvement to reach the 40-20 goals of the Partnership for Patients, and to sustain the gains that we've already made. I mean, many of us who've been working in quality improvement for a long time know as soon as you take your eye off the prize, it tends to deteriorate. And so we're here to sort of keep ourselves focused, keep ourselves moving forward, and sustaining those gains that we have made, if you'll recall back to the arrow slide that we looked at very early on. So all I can say is great work. We appreciate being able to work with you, and we look forward to working with you over the coming year. So I think Jason gave some instructions. If you have questions, you can chat those into the answer box. Do we have any questions, Jesse?
And there may have been some audio issues at the very beginning, so some participants may not have heard my initial introduction. So we've had everybody muted. If you have questions, feel free to type them into the Q&A box on your WebEx, or right now we are going to have all the lines unmuted. and you can just feel free to speak up with any questions or comments that you have. So it may just take a minute to get those lines unmuted. And our colleagues that are helping us with the tech stuff of this, Amanda, if you could just let me know when those are unmuted, that would be great.
And while we're waiting for that, let us just say that this will be posted on our website. So if you have colleagues who feel would benefit from listening in, it will appear on our website probably in a couple days. Everything that goes to our website has to be 508c3 compliant, and it takes a little bit of time to make sure the slides are 508c3 compliant, and we have the transcript available to post with it.
Okay, I believe everyone is unmuted.
Thank you. Does anyone have any questions, comments, observations? Well, this might be the first time I've been so clear that nobody asked a question. You know, please feel free to chime in if you have anything.
And send a text if you're talking, but we're not answering you.
Yes, Marlene, you have a question.
Yeah, I just was wondering if we could get a little more clarification around affinity calls. I know I've had some dialogue with Jason about falls and pressure ulcers, but I'm not sure that there's been, if we're going to do affinity calls for all the topic areas, or if we'll know when we're going to make that decision.
Well, we're moving forward on your affinity calls right now. We're working with the subject matter experts to review all of the process. So some people may remember that one of the things that we decided to do early on was say there are 10 adverse event areas that we're looking at, but you can really cluster them down into 4 areas. Those things that happen at the bedside, those things that are hospital-acquired conditions, then readmissions and OB were really the 4 areas. So what we may end up doing is the hospital-acquired infections as a single affinity call, and we're working with the subject matter experts to figure out what's the best way to do that, because a lot of the quality improvement interventions you put in place there cut across all of the areas. And we appreciate how hard this work is and how many things people are trying to do in hospitals and all the diverting priorities like new electronic medical records coming on board, getting ready for meaningful use, Joint Commission doing surprise visits, you know, lots of things are going on. And so as much as possible is that we can group these things in a meaningful way is what we're trying to do. So we'll know more about that over the next 2 weeks. We did meet with all the subject matter experts and ask them to review those things. Other questions? Jesse, anything typed in?
Nope.
Go ahead. Marlene.
Marlene has another question. It has to do with data submission. I've already asked this for myself, but I thought maybe the group might be interested, is what are we going to do with any new facilities that we bring on in terms of adding that to the report? So we're going to do separate reports, we're going to do the ability to break it out, or are we just going to have one big report and just add them in and have a larger N?
It depends is the answer to that. So one, it depends on the number of hospitals. 2, it depends on whether or not they can give us the historical data for the baseline. But the general consensus right now that HENS across the board are looking at, and this has been approved by the evaluation contractor and CMS, is you would create a separate cohort. And so for the new hospitals coming on board, they would be handled as a separate cohort. That doesn't mean for their tailored, so there are 2 ways that the information gets reported. One way is that information on an aggregate level, so for HEN-wide data reporting, we report to CMS. We don't identify any hospitals. But for the tailored reports, depending on, you know, the bed size category they fall in and, you know, the amount of data that we have, we may group it all together so that they get meaningful reports. And that would be an internal tailored report that might group it together. Does that make sense? Other questions? Well, I would really encourage you to please think about the extra program. I think it's a fabulous resource. And then, again, we'll use the information that we get from those requests to plan the regional in-person meetings, as well as being able to reach out to you and giving you the support that you need. We look forward to continuing to work with you. And again, the data submission deadline for this next quarter is February 20th. So there's no reason to not say, let's give you the gift of some extra time in your day. Maybe go for a walk, clear your head, take care, and thank you for everything that you've done.
Thank you.